Okay, let's cut right to it. Labor and birth can feel like you're trying to drink from a fire hose, right? So today, we are cutting through all of that noise. We're going to give you the must-know priority actions that will be a total game changer for you on the NCLEX and, on the actual floor. Let's dive in.
So picture this. You're at the bedside. That monitor starts screaming at you, a heart rate of 180, and it's been stuck there for 10 minutes straight. Your first instinct is probably to grab the phone and call for help. But is that the first thing you do? This is a classic NCLEX trap, and knowing the real answer is absolutely critical. You change the mother's position first, always. That heart rate of 180, that's fetal tachycardia, and it's a non-reassuring pattern. So before you even think about picking up the phone, your hands-on intervention to get more blood flow to that baby is the absolute priority. Seriously, what you do in those first few seconds can make all the difference.
Okay, so to really get why we do what we do, you need to know the basic code for labor. We're talking about the 4 Ps. And don't worry, we're doing this speed run style.
Just think of it like a road trip, okay? The powers, those are the uterine contractions. That's your engine, pushing everything forward. The passageway is the pelvis and all the soft tissues. That's the road you're on. The passenger, of course, is the fetus. That's your little traveler. And last but not least, the psyche, which is mom's emotional state. Well, that's the driver's mood. All 4 of them have to be working together for a smooth ride.
All right, that's enough theory. Let's get into the real-world action plan. This is the stuff you need to know when you're on the floor and things are happening, like right now.
First things first, is it actually go time, or is this just a false alarm? Here's your 30-second cheat sheet. With false labor, you'll see irregular contractions, and they might even stop if she gets up and walks around. But true labor? Those contractions just keep getting stronger, longer, and closer together. But here's the real key, the one thing you have to look for. True labor causes cervical change. We're talking dilation and effacement. If the cervix isn't changing, it's not the real deal. Simple as that.
So let's get back to that heart rate monitor. A non-reassuring fetal heart rate is a huge red flag. There are 2 big ones you gotta know like the back of your hand. First is tachycardia. That's a heart rate over 160 that lasts for 10 minutes or more. The other is bradycardia, a heart rate under 110 for 10 minutes or more. Both of these are basically screaming that the baby is in distress.
So when you see one of those patterns, what's the playbook? It's an ordered list, and the order is everything. 1. Change mom's position, get her on her side. 2. Slap on some oxygen, 8 to 10 liters with a face mask. 3. Get those IV fluids running to boost her volume. 4. If she's on oxytocin, you stop that infusion immediately. Then, and only then, do you notify the provider. Follow those steps in that order.
Okay, next up, the water breaks. Sometimes it happens all on its own. We call that spontaneous rupture of membranes, or SROM. Other times, the doctor or midwife might do it on purpose. That's an artificial rupture, or AROM. Either way, once that water breaks, a new clock starts ticking.
You hear that telltale gush of fluid. Your patient's water just broke. What is the very, very first thing you check? I mean, before you look at the color, before you write down the time, what is your absolute #1 priority? You check that fetal heart rate. Instantly. And here's why. When the membranes rupture, there's a serious risk that the umbilical cord could slip down ahead of the baby. That's a prolapsed cord, and it can completely cut off the baby's oxygen supply. The first sign of that disaster? A sudden, scary drop in the heart rate. All right, let's talk stages of labor. How do you know for sure that you're in the 2nd stage? It's actually pretty simple. There are 2 definitive signs. 1, the cervix is completely 100% dilated to 10 centimeters, and 2, the mother feels this crazy, overwhelming, spontaneous urge to push. When you see both of those things happening, you know it's time to have a baby.
In the 3rd stage, well, the baby's out, so this stage is all about delivering the placenta. The key sign you're looking for here is placental separation. And the classic sign of that is a sudden gush of dark blood, which usually happens about 5 to 30 minutes after birth.
Okay, I need you to really tune in for this next part. We are moving into the critical safety alerts. These are the red alert situations you absolutely cannot afford to miss.
Okay, for real, no distractions. This next one is a non-negotiable in your nursing practice.
We're talking about something called vena cava compression. Now listen up, because this is one of the most important things you'll hear today.
When a pregnant woman lies flat on her back, the heavy uterus can literally press down on her vena cava. That's a major blood vessel, and squishing it can choke off blood flow back to our heart, which means less blood flow to the placenta and less blood and oxygen for the baby. It's a silent emergency waiting to happen.
So what does this mean for you? Your action here is so simple and it is totally non-negotiable. You never let a laboring mother lie flat on her back, ever. You always have her in a sideline position, or if she has to be on her back for some reason, you wedge a pillow or a rolled-up blanket under her right hip to tilt that uterus off the vessel.
Okay, you've got the knowledge down, but can you apply it under pressure? It's time for a rapid response quiz to make sure these priority actions are locked in. You ready for this?
Question 1. A client is in labor. Which findings tell you she is officially beginning the second stage? And it's a select all that apply. 1. The contractions are regular. 2. The membranes have ruptured. 3. The cervix is dilated completely. 4. The spontaneous urge to push is initiated. Stop. What's your first action? 3, 2, 1.
The answer is 3 and 4. Look, regular contractions happen pretty much throughout labor, and her water can break at any time. The definitive signs, the ones that tell you for sure that you've entered stage 2, are a completely dilated cervix and that undeniable can't-stop-it urge to push.
Okay, question 2. Your patient's fetal heart rate monitor is showing a steady 100 beats per minute, and it's been that way for 12 minutes. What is your priority nursing action? 1. Document the finding. 2. Prepare for a C-section. 3. Reposition the mother. 4. Check her blood pressure. Stop. What's your first move? 3, 2, 1.
The answer is 3. Reposition the mother. A heart rate of 100 is fetal bradycardia. And while you might end up doing those other things later, your immediate first-line priority intervention is to change her position and try to improve blood flow to that baby right away.
Last one. The provider just performed an amniotomy. They just broke your patient's water. What is your very first assessment? 1. Check for meconium in the fluid. 2. Assess the fetal heart rate. 3. Check the mother's temperature. 4. Document the time. Stop. What do you do first? 3, 2, 1.
The answer is 2. Assess the fetal heart rate. Remember, right after that water breaks, your number one priority is to rule out a prolapsed cord, and you'd spot that as a sudden drop in the baby's heart rate. You know, labor and birth is probably the number one topic that students overthink. Did this help simplify it for you? Let us know in the comments and be sure to save this for your next shift or study session. You've got this.